Good morning, I'm Penny Barnard, and we're going to look at infant mental health in the mother-child consultation in primary care. You might know about infant mental health, but we're going to look at what this is and why it's important. We're going to look at some of the risk factors that affect it. We're going to look at some of the things that the doctor might notice in the consultation, mother-child consultation, and then how you, the doctor, can promote infant mental health, both in this consultation and in the community. So what is infant mental health? The first 1,000 days from conception to 24 months is a critical stage for infant development. This is the stage in which they develop a secure attachment, they can regulate and express emotion, they explore the environment from a secure place, and it's the beginning of development of empathy, and that is the ability to understand the feelings of others. Many countries have first 1,000-day projects, and I was delighted to see that from Iceland to Indonesia to many countries in Africa and all over the world, they are giving the first 1,000 days extra attention, both for feeding, stimulation, and maternal-child interaction. Why is infant mental health so important? Well, it's important for long-term emotional health into adulthood, and I'll leave you to look at that reference. But interestingly, it's also important for long-term physical health and well-being. Many causes of mortality and adult diagnoses of physical and mental disorders can be tracked back to poor mental health in infancy and childhood. Infant mental health is also important because it's the basis of other development, so motor skills, language skills, and cognition in the infant happens at this stage. And evidence that early experience influences brain development because the brain plasticity is at its highest during this period, and its ability to modify and rewire itself is at its best. So it is critical to recognize problems and provide necessary support to the mother-child dyad. Infant mental health is closely related to secure attachment. The infant needs to see the world from a safe space and have food, comfort, and emotional needs met. So the mother or caregiver has to be physically and emotionally present. And just to say it yet again, the mother-child dyad relationship has the biggest impact on infant mental health. So what is our response? Our response must be commitment to care for this mother-child dyad and family. We're not just looking after the mother, we're not just looking after the child, we're looking after the mother-child dyad within the context of the family and the community. The factors that can disrupt mother-child attachment and present a risk to infant mental health are anything that can cause extreme stress to the mother. This can disrupt the mother-child dyad relationship. So in the context of family medicine and maternal and child health, we need to be committed to the care of the mother and the child, and we need to notice what happens between the mother and the child. We also need to know the context into which we are helping, and we need to build trust. These are some of the risk factors for infant mental health problems, and I've divided them into antenatal factors, birth and postpartum factors, family and support factors, and environmental factors. A good history takes time, and I'm aware of the fact that many clinics have got time constraints. We have lots of patients to see, but I can't emphasize enough that taking a good history is going to help in the long run. So I often, when a mother comes in, I will ask her, how is your pregnancy? Because I find that finding out how difficult the pregnancy was, she might tell you that there were infertility issues before she fell pregnant, difficult pregnancy, maybe a threat to the pregnancy, maybe she thought she was going to lose the baby. This can lead to antenatal anxiety or antenatal depression. So we need to know these things. looking at maternal age, an extremely young mother, sometimes very old mothers or relatively old mothers who might have had infertility, and this might be a very precious baby, and there might be a lot of anxiety about the baby, or an unwanted pregnancy. Um, Sometimes the mothers will say, I just didn't know how I was going to do it. I felt completely overwhelmed. I didn't think I could have this baby. I didn't think I could cope with another baby. These are little cues we need to pick up on. These are factors that are going to red flag us for risks to this baby's mental health. And then finding out about the delivery. What was your delivery like? Sometimes it's not what they expected, but they're completely okay with it. But if it was a traumatic delivery where they perhaps worried about the baby not being not being alive at the end of it, if they're worried about their own health throughout the delivery, that could also cause problems. Um, Maternal anxiety and depression. This is a very important thing. Looking at antenatal anxiety and depression highly correlates with postpartum anxiety and depression. So we really need to know about this. But one can see mothers who are anxious when they come in. Sometimes it's an over fussy mum. Sometimes it's a depressed mum who's actually very flat and not responsive. We must never overlook depression in the father. Paternal depression actually impacts on infant mental health as well. A premature baby, a difficult delivery, and a premature baby who then goes to ICU is also a very big risk factor. There are often feeding difficulties and physical separation from the mother. So at this point, I just want to say kangaroo mother care, skin to skin care must be encouraged if at all possible. And they've actually found that even for small, sick babies, they benefit by being out of their incubator and on the mother's chest. Sometimes when there's been an unexpected abnormality, an unexpected genetic condition or illness in the family, which involves prolonged hospitalization, another physical separation causes problems in the mother-child interaction and for infant mental health. So we need to just know about all of these things. And then family and support factors. Financial strain and job loss obviously creates severe stress. Immigrant families who are culturally isolated and who don't have their own extended family, don't have their own mothers, are at risk. Single parents are often at risk, but sometimes they have got great support systems. So we just need to find out what the support system is. Where there's abuse in the household, physical, mental, or substance abuse, that is a factor that we need to red flag for problems. And then the part that we feel so unable to help are those environmental factors, where there's climate change and food insecurity, mothers who are bringing up babies in poorly ventilated, very hot shacks, and who are struggling to get to the next day because they don't know what they're going to eat themselves, let alone how they're going to feed their children. Where there are natural disasters, floods and tornadoes. I remember about 10 years ago a mother giving birth to a baby in a tree during a flood in Mozambique, and just thinking what an incredibly difficult start to life for both that mother and baby. We've all seen pictures of war and civil unrest and know what trauma is associated with that. And there are many others. Some of you will know of situations that are risk to mother-child interaction and infant mental health. So what are some of the signs that you, the doctor, are going to notice in the consultation? You've taken a good history, you've got some ideas of some of the risk factors, and now we want to look at the cues to explore. And some of them are very subtle and some of them are quite obvious. So an unresponsive mother, if she comes in and her baby's unsettled and crying and she's just not doing anything about it, we need to find out why. Is she absolutely exhausted? Is she depressed and she has no emotional reserve? is this baby sick and she doesn't know what to do about it? Is she overwhelmed? The other one is an unresponsive baby. So the baby may not be smiling, maybe over 6 weeks, should be responsive, should be engaging, should be smiling, and is not smiling. Maybe the baby's not reaching its developmental milestones and is feeding poorly. These are little clues that we can explore. Poor eye contact between mother and baby. I think this is something that I look at straight away when mothers come in. We know that kind of cradle position where a mother's holding her baby, and the eye of the mother to the eye of the baby is the ideal distance for the baby to focus on the mother. And it's just so interesting that that's a natural position to hold one's baby when there's poor eye contact or the baby is almost seeming absent. So this is active avoidance of eye contact from the baby to the mother. These are things we need to just follow up on. I put in here an intrusive mothering style because sometimes when the mother actually sort of knows that there's something wrong and she's not really connecting with the baby, there will be an intrusive mothering style that you'll see. She'll squeeze the baby's face. She'll be a little bit over large. She'll be a little bit overstimulating, and the baby sometimes sort of responds by pulling away, not wanting to be held. And we need to be very alert for that extremely undemanding baby. So when the mum actually says, oh, I put him on a blanket and he's fine by himself for many hours, that sometimes is something to be alert for. Further cues and signs that we're going to look for is a mother who has expectations beyond what the baby can do. So she's wanting this baby to do things like sleep through the night, and the baby's 6 weeks old. She's wanting to train the baby to do something, and the baby's not able to. She's not in touch with the baby's abilities and baby's feelings. A baby that has difficulty calming down. So perhaps I immunize a child and he's very upset, and the mother cuddles him and calms him down, and then eventually he calms down. But some babies are unable to calm down. They just carry on crying for far longer than appropriate. Often a mother will tell you that he cries all night. A baby that's not making noises. So babies from about 3 months initiate communication. They make some cooing noises because their mother's been talking to them, and then the mother coos back or babbles back, and you can see that they're connected. When there's an absence of this connection and communication between them, this is a bit of a cue. A baby that's constantly fussy, screaming, and crying easily or crying continually is another cue that we need to know, why is this baby fussy? But this is not a diagnosis. This is just something to be aware of, because babies can be tired, have a bad day, be hungry, and we always must exclude illness. So how are you, the doctor, going to help this mother-child diet? First of all, we're going to be committed to the overall health of the mother and child diet. And this often takes time. It takes time taking an adequate history. It takes time looking for cues. And it's difficult in a busy clinic situation. That thorough history, as I said earlier, looking at antenatal factors, looking at birth and postpartum factors, looking at the family support system and the community support system, and knowing what environmental factors there are. And that adds context, and that's also one of McWhinney's principles of family medicine, is knowing the context. So looking at antenatal mental health status, the birth experience, and the infant health. Notice what's happening. Observe mother-child interaction. Observe maternal responsiveness. Look at the infant behavior. Now see this as a really important thing. And then actively ask about maternal mental health. There's an Edinburgh Postnatal Anxiety and Depression Scale, and this tool has been validated for use in low middle income countries, and it's free to use. It's a 10-question self fill-in questionnaire. and gives lots of information about what's going on in maternal mental health. I really can only promote it. How can the doctor help this mother-child diet further? Opportunities are always there. Every visit is an opportunity for health promotion, education, and intervention. Sometimes it's important to normalize certain things that a mother might feel. So it's easier to get information by saying, I find that lots of mothers at this stage are feeling a bit overwhelmed, they're feeling tired, sometimes they feel a bit worn out, and sometimes they're feeling a little bit low in mood. I don't often use the words anxiety and depression. I find that it immediately puts things in a box, and sometimes the mothers don't want to admit to it. But saying, giving other feeling words, and then the mother might say, oh, I feel depressed the whole time, or I feel very anxious, I feel very worried, I'm not really able to do my normal things at home because I'm so worried, and just creating a place where mothers can talk. And then not saying what you should do is this, but saying some of the things that some mothers find are helpful are the following, and then giving some suggestions in a way that you are aware of what she is responsive to, and helping her to find what she's going to find helpful. Then modeling communication with the infant. So talking to the baby is always very, very important. You're modeling communication. You're saying to the baby, hello, I see you as an important person in this consultation. I'm not overlooking you and only talking to your mother. And then showing the mother that, look what your baby's saying. Your baby's actually starting a conversation with you. This just encourages her to carry on communicating with her baby. I like to refer mothers and babies to groups before it's really crucial. So mother-baby groups are very important. You might need to refer for depression and anxiety. There are such support groups around. I think most countries have anxiety and depression support groups. But if they don't, bring them back to you so that you can be helpful. Helping her identify her support system is very important. And sometimes the support system is an unexpected one. It could be other mothers, it could be a cousin, it could be somebody who's in a similar situation, it could be somebody that's actually much older who can help from afar, an aunt or a grandmother who can actually give wisdom from another perspective. Showing empathy and encouragement. So we want to communicate that this is a very important job that you're doing. Communicating with your baby is very important, and caring for this baby can be difficult and tiring, but this is such an important job that you're doing. Communicating with the mother what she's doing well. She needs the encouragement. She needs a cheerleader. So be the cheerleader of this mother and of this caregiver. And then what can you as the doctor do to promote infant mental health in the community? Awareness programs might mean that there are posters regarding infant mental health and postnatal depression and anxiety in the clinic, in the library, in the community centres. Awareness is very important. Education programs for the clinic staff, and I say especially nurses. Frequently mothers will talk to nurses because they don't feel quite as intimidated. Maybe these nurses live in the community and they know that down the road is a baby that cries all day and the mother is not able to respond. Initiating the use of a postpartum screening tool for maternal anxiety and depression, like the Edinburgh Postnatal Depression Scale at your clinic. This increases awareness of this and might be an important factor for picking up postpartum depression and babies at risk of infant mental health problems. Supporting mother and child groups for socialization and for stimulation. I can remember being part of a group where we looked at mothers who had children with genetic disorders and finding out from them what things helped when they felt sad. And some of the mothers said singing. They go and find groups of other mothers and they sing together and they feel less sad when they sing. Creative groups, we looked at, I found a group in Ireland where mothers and babies were invited to come to an art workshop and to creatively put together a picture of the feelings around birth and delivery and being a mother. There are things that are already there, perhaps. Story time at libraries brings mothers and babies together. Cooking groups, child education groups, there's so many. And I want to say, encouraging mothers to get togethers in their homes, in their parks, in community centres, in sports centres, and being an advocate for all these places to make to be baby friendly so that mothers don't feel odd being in places with their babies. They must feel welcome to be in community centres and sports centres and parks with their babies. Mentor mothering programs is something that I read about where slightly older mothers moved into the space with mothers that were really not coping, and perhaps for a few days they had somebody who had been a mother in the house with them and helping them and showing them and sharing the parenting or the mothering with them, with the biological mother. And this seemed to help postnatal depression and mother-child interaction. So I want to just leave you with the fact that mother-child interaction and infant mental health is a really important aspect of family and community health, and that you can be doing something towards this. Thank you very much.